Nibha Mishra, your time starts now.
Good afternoon, everyone. It's an honor and privilege to be presenting in this particular session. Today, I am going to present my title, research title, Advanced Glycation End Products are the Biomolecular Biomarkers of Proliferative Diabetic Retinopathy. I have no financial disclosures too. Diabetic retinopathy, as we all know, is a major neurovascular complication of diabetes mellitus. We are living in a world where diabetes mellitus is growing at the rate of epidemic, as well as what we are seeing is the diabetic retinopathy, which is the vision threatening or the functional group of people. It is also causing a lot of problem. So we are leaving no stone unturned to find out our ways to get through with this disease. So starting with the main thing, that is the pathogenesis. Hyperglycemia is the main triggering thing which happens in diabetic retinopathy. What is being most studied nowadays is the non-enzymatic glycomatic reaction which acts on the proteins, lipids, and nucleic acids, which forms the basic skeletal framework of all our body structures, and that results in the formation of advanced glycation end products. The molecule which I have studied and is the most common is the N-carboxymethyl lysine. And here comes the concept of metabolic memory. What is metabolic memory? That once the proteins, lipids, and nucleic acids are irreversibly damaged with the formation of ages, even on reversal of hyperglycemia, it's not going to go back, and this damage is permanent. So my objective is to evaluate the role of ages as the biomolecular biomarker for PDR in type 2 diabetes, because that is the main vision-threatening issue. My inclusion criteria consisted of, it's a cross-sectional study at the tertiary care center, consecutive ophthalmologically naive type 2 diabetes mellitus patients ranging from age 40 to 65. After proper fundus examination, on the basis of ETDRS, we divided them into no diabetic retinopathy, NPDR, non-proliferative, and proliferative diabetic retinopathy, each group having 20, and an age and sex match controls were taken. The exclusion criteria was that no retinal vascular pathology should be pre-existent. There should be no prior treatment, treatment naive patients, and the conditions where NCML or ages levels are high, like in Alzheimer's disease or pulmonary fibrosis, should be excluded. We did a detailed data connection of demographic detail, best corrected visual acuity, and fundus examination was done. The blood investigation was done. The glycemic status was assessed by fasting postprandial and HbA1c, and assay of NCML was done by quantitative sandwich enzyme immunoassay technique. The main statistical analysis where our research was based was the receiver operating characteristic curve analysis. Our study was, all the 4 groups were age and sex matched. What we can notice significantly here is that the NPDR and PDR groups have a duration which is comparable. There is no significant difference. Definitely the main visual acuity is decreasing as we are going towards a more severe disease. And as per ANOVA, all the 4 groups are showing that there is a p-value more than 0.001 increase, and there is a significant decrease of NCML. But what is noticeable is fasting PP, postprandial, and HbA1c and NPDR and PDR is comparable. So here comes the role of NCML. We have plotted a ROC curve adjusted for age, sex, and HbA1c, and what we found that the area under curve came out to be 0.842, and as we know that this is a good, because 0.9 to 0.8 values are considered good for ROC curve analysis. So also we can see that the blue line is PDR line, and it is more towards, away from the 50-degree axis and more towards the y-axis, that is for sensitivity. And thus, this is a very good diagnostic tool for dichotometers finding that yes or no, the disease is present or not. So the ages-range axis lead to continued cellular dysfunction. Ages cause retinal parasite apoptosis, stimulate VGFs. Ages trigger oxidative stress. Ages thus are the new therapeutic targets. We can see that everything is being affected by them. So the glycemic control, HbA1c, which is being used, why not use it now? There are genetic variants. Sometimes it's reversed also, but we see that the patients are saying, I'm still having the disease. So ages are the major biomolecular biomarker, pathophysiology of the evolution of diabetic retinopathy, and are novel therapeutic targets along with anti-hypertensive, anti-glycemics, and they are being studied now. Ages are the new age tools of translational medicine, and we should put a focus on that. Thank you.
Thank you, Dr. Nibha. Is there any questions from the... No? Okay. We are running a little short of time. Get your spell checks done when you do. So discussion in 2 slides was without an S. Yeah?
Okay.
Okay.